Hello, everybody, and thank you for joining us and making time to be with us for another one of our Meet the Specialist sessions. These sessions are designed as a short little vignette so that you get to see what the specialist looks like and sounds like and a little bit more about their expertise. It's a little bit more way of getting personal with our specialists and helping you when you're looking at a specialist to book, someone perhaps that you haven't booked with before. With us today is Dr. Michael Jones, who is an ophthalmic surgeon and ophthalmologist. He is currently the head of the Department of Ophthalmology at the Children's Hospital in Westmead here in Sydney. He's also a senior clinical lecturer in ophthalmology. He's done a specialist fellowship in Canada where he won a very prestigious prize called the Morin Award. He has a particular interest in retinoblastomas, which is a particular type of children's eye cancer. And he's been involved in all sorts of other amazing research, and we are absolutely thrilled to have him on our expert panel at MAG. So I will hand over to him to give him a little bit of a brief about his expertise and the kind of matters he comments on. And then if you would like to ask some questions at the end of that, please feel free to do so. Thank you so much, Dr. Jones.
Thanks, Michelle. So that's a very nice introduction. It covers a lot of the bases. So I'm a clinical ophthalmologist and a clinical researcher and a clinical academic as well, so I cover a few different roles. I work in ophthalmology like a lot of ophthalmologists across the range of different subspecialties. So as well as being, as I was mentioned, at the Kids Hospital at Westmead, I work at the Sydney Eye Hospital. I'm chair of the Medical Staff Council there, so I've been there 12 years and at the Kids Hospital about the same, and head of department at the Kids Hospital for about 8 years. And that means that I do see and treat adults and children. And ophthalmology, if you haven't had any particular exposure or experience with it before, is something which, as you go through the training, we do, of course, cover all the bases. And then after practice, in particular, when you work in a metropolitan area, it gets a little bit more specialised. So for me, as well as doing general ophthalmology and cataracts, I'll do pediatric ophthalmology, and then in particular with that, the subspecialty area is the eye cancer retinoblastoma, and with adults in particular as well, the specialty area that I sort of delve a bit deeper into through the Sydney Eye Hospital Clinic in particular is the strabismus or turned eye surgery. But I think being Australian trained, and I trained at Sydney Eye Hospital before I went to Canada, and I think you can get a very comprehensive training here. So we sort of usually do see a broad range of injuries and matters with ophthalmic conditions. And I've had experience over many years now looking through medico-legal cases with those injuries and doing the appropriate grading and whole person impairment from vision system impairment. So I think that's knowing that side of things too means that you can pretty much deal with most of the things that come across your desk. So there's always a little bit of fear in ophthalmology. People feel, in particular, even with other medical specialties, they sort of draw the line there because they don't really know so much about it. And I suppose we can all say the same is the other way around for a lot of other subspecialty areas. But I think it's commonly involved. It is a very important part of people's lives, people's independence and livelihood in particular. And it's extremely emotional and traumatic having eye injuries. And there's a component of this which, therefore, people tend to report problems with their vision very quickly, and they're very clear about the fact that if anything's happened in particular with a legal or a medical legal case that's affected their vision, then they're going to want to talk about it or bring it up. So and again, another very important sort of point of a lot of cases is that there'll be questions asked about how it was related or how relevant it is, because people care about their vision so much, understandably. So that's a bit of a summary. I hope that sort of gives you an idea who I am and what I do. Apart from that, I'm, a dad. I've got 3 kids. I understand pressures of life, all those things, but.
Thank you so much for that introduction. I actually have a question from someone who was unable to attend, and then I'll open up to the other people who are with us today. They have some questions. Now, I have 2 questions, and the first one is, say that you have reviewed somebody, say 2 or 3 years ago, post an accident as a result of a workplace injury or a medical negligence or what have you. And subsequent to that, a new technology has come into play that could restore their sight or improve their vision. Have you ever had to comment on matters like that? And how do you go with sort of looking whether that technology is going to be applicable to an already damaged person's eye?
It can be relevant because there's cause and effect that which continues after cases, and there can be very long-term sequelae from particular injuries. And I think you would see in ophthalmology that it is a very technically equipped specialty. There's a lot of things that we do surgically in particular, which is constantly evolving and developing. And with the fact that we look exactly at the pathology, we're looking at the eye, in the eye. And so the imaging and the investigations that go along with that are really very sophisticated. So it probably comes in two ways. If you think about the actual treatments, we've been very good and very much up to speed with a lot of what can be done in terms of repairing penetrating injuries, putting lenses in eyes, treating retinal detachments, and that side of what would commonly occur with vision system impairment for a long time, and nothing's changed that dramatically. There isn't like a new wonderful treatment for cataract, for example, although we're getting better at doing those things. But you would actually see in some cases where there have been times where you're looking at the potential to improve someone's vision, where there may be an injury before which is deemed to be unsuitable for that, or it's too dangerous to do that. But funnily enough, with the cases that I've commented on in my practice, it hasn't actually happened that often. Like very often, that hasn't been such a big part of it. But what is very important is that investigation side. So there may be questions over what the pathology was and how you quantify or how you look at that pathology. And for example, there's an imaging modality which has been around for up to 20 years, but in clinical practice, very, very much at a sophisticated level for 10 years, called ocular coherence tomography, or OCT, which is now the sort of thing where you walk into any optometrist or ophthalmologist practice and they'll take a scan of the back of the eye and the macula, and you get a high definition cross-sectional view of the pathology in a layered section of the retina. That's incredible. And when I trained as a registrar, that was something that was, still amazing, but very sort of fuzzy resolution, and the ability to actually define diseases, and actually the pathology that we had words for increased exponentially when we had the imaging to define these things. So definitely that's something that isn't just in that one example, but in a lot of other examples with imaging for eyes. And so I'd say that would be something worthwhile. Like if you think that there's been an injury or an accident, and then we're looking at not just even how you can restore the vision, but how you could quantify the injury, how you could actually look at the effect of that, and then also then be able to look at that cause and effect for the future. And then, treatment is always evolving. I don't think I can, see all the time advances in different types of treatments, with minimally invasive treatments for glaucoma, for example, and again, more sophisticated vitrectomies with smaller gauge vitrectors, and there are advances, but the sort of things that we do are, we've been up to speed for a long time. And then the only other thing I'll just finish off by saying is that, really, I think it does depend on how people see. A lot of what we do with whole person impairment and vision system impairment is still based on the AMA Guide to Permanent Impairment 4th edition, and it really does come down to some very fundamental things, which is what we always keep in mind when we treat people: is how well do you see? And that includes your vision, your visual field, your eye movements, and then if there's something else which is making your life or your vision difficult. So just to remember that those sort of are very basic quantifiable parts of what happens with eyes, because it really is your vision. So we've always been able to do that very well, and we can continue to quantify that in the same way.
Of our other participants here, do you have a question for Dr. Jones? No, it's probably because he's answered it. I have one other question, and that is in relation to LASIK surgeries.
Sure.
And the question comes from an insurer case manager. And the question is, when in relation to a workplace injury or a workplace situation where a person's vision is deemed not to be good enough for the task they're doing, should LASIK surgery be considered to be the responsibility of the employer?
In very specific circumstances, that could be the case, and not necessarily just LASIK, but I think you'd need to think in a more broader sense of laser refractive surgery. And the more likely scenario wouldn't be LASIK itself, because LASIK is a way of putting a refractive change into someone's eye by sculpting the cornea. So they could have some, more commonly it's just because people don't want to wear contacts or glasses and they may be short-sighted, and you can put that power of focusing into the eye by actually changing the shape of the cornea. But laser refractive surgery also includes other areas of treatment where you might do it in a slightly different way, where LASIK lifts a flap and replaces a flap, and you might just actually use the laser to remove scar tissue. Or there could be trauma from, in particular, even a very common thing is anyone who gets a blunt injury and they lose the skin of the eye or an epithelial defect can have a lifetime of trouble with the skin sticking down again. And you can do a laser called PRK, and the photorefractive keratopathy can replace that adhesion by resurfacing the cornea, and then the corneal epithelium actually sticks a little bit better to the cornea. So yeah, there it is. Actually, that's one example where it could be relevant. And then again, in removing scar tissue or for treatment, it could be relevant. And then we're always, of course, if there was a refractive error when I repair a penetrating eye injury, there could be astigmatism or change in the cornea, even if it's outside the central cornea and the injury, it's just changed the shape of the cornea. But then if it's a direct result of the injury itself, then I'd say then that would absolutely be something that you would comment on, because it's no different from saying if someone had an injury where they developed a cataract and needed cataract surgery and you had to replace the lens in the eye with a penetrating injury, then absolutely that's always deemed to be part of the responsibility of the employer or from the injury, because again, there's a very direct cause and effect from that incident.
Lovely. And thank you so very much for making your time today. And so now people will be able to see Meet the Specialist, Dr.
Pleasure.
Michael Jones, on our YouTube channel. For those of you who attended, the recording will come to you within a day or so. And thank you again for your time, sir. Have a great rest of the day and a lovely weekend with your family.
Thank you. All the best. Thank you.